So, good morning everyone. These are the report of Group 1 and our topic is celiac disease. So, these are the list of contents, definition of the disease, causes or risk factors, assessment findings, diagnostic tests, medical and surgical management, nursing interventions, and family education and reference. So, what is celiac disease? Celiac disease or CD or gluten-sensitive enteropathy is a complex autoimmune genetic disorder with multiple contributing genes. CD affects the small intestines and is characterized by a permanent inability to tolerate dietary gluten. However, it can have systemic manifestations as well. Gluten is a protein found in wheat, rye, and barley. The disease process is reversible with strict adherence to a gluten-free diet. These are the cause and risk factors. Celiac disease or CD is an immune-mediated disease. The two necessary components of the disease are exposure to gluten and a genetic predisposition resulting in immune activation to gluten. Linkage studies have identified several genomic regions that probably contain CD susceptibility genes. The genes implicated in celiac disease are HLA-DQ2 and HLA-DQ8. However, these genes can be found in 30% of the normal population as well. A familial connection is found in 5% to 15% of celiac patients with an 83% to 86% concordance rate among zygotic twins. So, HLA-DQ2 and HLA-DQ8 are specific human leukocyte antigen molecules that are associated with an increased risk of developing celiac disease. These molecules play a crucial role in the immune system by presenting antigens to T cells and regulating immune responses. In the context of celiac disease, individuals who carry the HLA-DQ2 or HLA-DQ8 genes have a higher susceptibility to developing an abnormal immune response to gluten, a protein found in wheat, barley, and rye. This abnormal immune response can lead to inflammation and damage to small intestine, causing various gastrointestinal symptoms and nutritional deficiencies. So, the the 5% to 15% familial connection rate indicates that a small percentage of individuals with celiac disease have close relatives such as parents, siblings, or children who also have the condition. The 83% to 86% concordance rate among zygotic twins highlights the strong genetic influence on celiac disease. When one identical twin has celiac disease who shares 100% of their genes with the other twin, there's a high probability that the other twin will also have the disease. This suggests that genetic factors play a significant role in predisposing individuals to celiac disease, although environmental factors can also contribute to its development. Number 2, the disease results in inflammation in the mucosa of the small bowel, especially the duodenum, the jejunum, and this results in damage to villi, which can be shortened or totally lost. The mucosal damage results in deficiency of enzymes on the mucosal surface, such as disaccharides, disaccharidase, and peptidase. This, along with a reduced surface area, leads to malabsorption. The body may be unable to absorb fats, fat-soluble vitamins A, D, E, and K, minerals, and some protein and carbohydrates. The severity of symptoms depends on the extent of affected intestine. If involvement is focal and limited to the proximal bowel, GI symptoms may be absent. Number 6, a number of conditions may be associated with celiac disease, including type 1 diabetes mellitus, mucocutaneous manifestations, dermatitis, herpetiformis, cystic fibrosis, seizures, peripheral neuropathy, autoimmune thyroiditis, adrenal insufficiency, systemic lupus erythematosus, rheumatoid arthritis, and other connective tissue disorders, sclerosing cholangitis, trisomy 21, unexplained folate or iron deficiency refractory to treatment, alopecia areata, dental enamel hypoplasia, risk of thromboembolism. Signs and symptoms. The age and mode of presenting signs and symptoms are extremely variable. Diagnosis may be made by ages to ages to 6 to 24 months when infants are introduced to cereal. However, more subtle gastrointestinal and extraintestinal symptoms often lead to diagnosis much later in life. Signs and symptoms, age 6 to 18 months. Number 1, impaired growth. Normal growth during early months of life. Slackening of weight followed by weight loss. Diarrhea, more frequent, pale, soft, bulky, greasy, with offensive odor. Recalcitrant constipation occasionally. Abdominal distension, anorexia, muscle wasting most obvious in buttocks and most proximal parts of extremities.
Signs and symptoms, ages 6 to 18 months. 7. Vomiting. 8. Seizures. 9. Loss of tooth enamel. 10. Painful pleuritic skin rash called dermatitis herpetiformis. Signs and symptoms of older children. First, complications of malabsorption. Anemia, vitamin deficiency, hypoproteinemia, hypoalbuminemia with edema, hypocalcemia, hypokalemia, hypomagnesemia, hypoproteinemia resulting from impaired vitamin K absorption, disaccharide intolerance with acid sugar containing stools secondary to altered small bowel mucosa, low bone density, osteoporosis secondary to decreased calcium absorption. Signs and symptoms. Signs and symptoms of older children. Diarrhea or constipation, overweight status, linear growth delay, abdominal pain, and fatigue. Diagnostic test. Serology testing looks for antibodies in your blood. Elevated levels of certain antibody proteins indicate an immune reaction to gluten. Second, genetic testing. For human leukocyte antigens, HLA-DQ2 and HLA-DQ8 can be used to rule out celiac disease. Capsule endoscopy. The test uses a tiny wireless camera to take pictures of your entire small intestine. The camera sits inside a vitamin-sized capsule, which you swallow as the capsule travels through your digestive tract. The camera takes thousands of pictures that are transmitted to a recorder. This test is used in some situations where an exam of the entire or end of the small intestine is desired. Endoscopy. This test uses a long tube with a tiny camera that puts in your mouth and passes down to your throat. The camera enables the practitioner to view your small intestine and take a small tissue sample, called a biopsy, to analyze for damage to the villi. Medical management. First, lifelong gluten-free diet. Avoid all foods containing wheat, rye, and barley and their derivatives because even a small amount, such as trace contaminant, may cause a pathologic response. Oats are naturally gluten-free. However, they are often cross-contaminated during the manufacturing process, so their exclusion may be recommended. Second, the small intestinal mucosa will always respond abnormally to dietary gluten, although clinical signs may not be immediate evident. Biopsy and serologic screening revert to normal with appropriate diet. Clinical signs of improvement are often seen days to weeks after proper diet is initiated, but can take up to 1 year in the case or more insidious symptoms such as delayed linear growth. Second, medical management. Adequate caloric and nutrient intake. Supplemental vitamins and minerals may be used when clinically indicated. Folic acid may be used if low level is suspected or detected. Vitamins A and D, iron supplements until anemia resolves, vitamin K if evidence of hypoproteinemia and bleeding, calcium if milk is restricted. Temporary restrictions of lactose and sucrose, disaccharides, from diet for 6 to 8 weeks may be indicated in some cases if these products are shown to worsen symptoms. Enzymes therapy that protects the mucosal lining from gluten exposure is being investigated in clinical trials. Complications. First, nutritional deficiencies, most important short-term risk which can lead to anemia, osteoporosis, and growth failure. Second, long-term risk of untreated CD include increased risk of lymphoma and adenocarcinoma of small intestine. Third, refractory CD. Fourth, seizures related to inadequate absorption of folic acid and buildup of calcium deposits on the brain. Medical management. First, lifelong.
So next is nursing assessment. Number one, obtain family dietary history as it relates to onset of symptoms. So first, need to check the family dietary history to relate to the symptoms belt and to know where the disease started. Kumuha ng family dietary history na nauugnay sa simula ng mga sintomas. Number two, assess child's nutritional status. Components of a complete nutritional assessment include a medical history, nutritional history including dietary intake, physical examination, anthropometrics, weight, length, or stature. Next, number three, check for the signs of infection. Check for the signs of infection if the patient has the symptoms of diarrhea, fatigue, weight loss, bloating in gas, and abdominal pain. The patient already have a celiac disease. So, number four, assess growth and developmental parameters. Basic growth assessment involves measuring a child's weight, length, or height and comparing these measurements to growth standards. So, next, nursing intervention. So, number one, provide gluten-free diet, being careful to avoid accidental exposure via cross-contamination while food is prepared and or cooked. So, avoid food with gluten in prepared food carefully to avoid cross-contamination while preparing food. So, number two, an initial diet high in protein, relatively low in fat, low in lactose, and free from gluten may be necessary if the newly diagnosed child exhibits severe malabsorption. So, like for example, initiate referral with the DN for precise diet recommendations. Next, soy milk or lactate drops may be indicated if the patient is exhibiting signs of lactose intolerance, and watch for fat intolerance in infants and young children. Number three, maintain NPO status during the initial treatment of celiac crisis or during diagnostic testing. Take special precaution to ensure proper restriction if the child is ambulatory. So, maintain NPO status during initial treatment of celiac crisis or during diagnostic testing. Provide parental nutrition as prescribed. Number four, encourage small, frequent appetizing meals, but do not force eating if the child has anorexia. Anorexia nervosa is an eating disorder characterized by extreme restriction of calorie intake and intense fear of weight gain. So, number five, note the child's reaction to food. Close observation of the child's responses to food may reveal other intolerances. Note and record. So, like for example, food taken and refused, appetite, change in behavior after eating, characteristics and frequency of stools, general disposition, behavior improvement, commonly seen within 2 to 3 days after diet control is initiated. So next is number 6. Be prepared to temporarily eliminate new food introduced if symptoms increase. So, if you have a celiac disease, you can eat the following foods which naturally do not contain gluten. Most dairy products such as cheese, butter, and milk, fruits and vegetables, meat and fish, although not breaded or buttered, potatoes, rice and rice noodles, gluten-free flours including rice, corn, soy, and potato flour. So number 7, a gluten challenge diet is not routinely indicated. A gluten challenge is recommended when a person is on a gluten-free diet but his or her doctor is unsure of whether or not the patient has celiac disease. So, number 8, provide the family with assistance to obtain a variety of gluten-free foods. Studies demonstrate the poor availability and expense of gluten-free foods led to dairy non-compliance. So, it is important to the family to provide gluten-free food to prevent disease progression. So, next is the family education. Teach parents about celiac disease and how it is controlled by diet. Help them to understand that severe long-term damage to the intestinal lining has occurred and must be controlled to allow for normal growth and development. So currently, the only treatment for celiac disease is lifelong adherence to a strict gluten-free diet. People living gluten-free must avoid foods with bread, rye, and barley, such as breads and beer. Ingesting small amounts of gluten, like crumbs from a cutting board or toaster, can trigger small intestine damage. Number 2, long-term follow-up with a qualified dietitian has been shown to improve compliance based on symptoms and follow-up serological testing. So, if you have been diagnosed with celiac disease, you may have been referred to a dietitian to help you remove gluten from your diet, or team of expert dietitians provide evidence-based expert guidance to help you manage the challenges of living gluten-free. Number 3, provide a specific list of restricted and acceptable foods to get the family started. Because there is much variation among brands of packaged foods, it is best for the family to check with the manufacturers. So avoid all products with barley, rye, triticale, a cross between wheat and rye, farina, graham flour, semolina, and any other kind of flour, including self-rising and durum, not labeled gluten-free. Be careful of corn and rice products. Number 4, teach other parents how to read labels on foods to identify those containing wheat, rye, and barley glutens and thus avoiding them. So, read the contains allergen. Number 5, provide information of substitute for wheat, rye, and barley such as corn, rice, potato, soybean flour, and gluten-free starch. So, grains, starches, or flours that can be formed of a gluten-free diet include amaranth, arrowroot, buckwheat, corn, cornmeal, grits, and polenta labeled gluten-free, flax, gluten-free flours, rice, soy, corn, potato, and bean flours, hominy corn, and millet. So, number 6, help the parents become comfortable in situation problem solving. Supply gluten-free cupcakes for birthday party to which child has been invited. So, go easy on yourself if you don't always get it right, but keep at it. Also try to be patient when the person who has to avoid gluten asks a lot of questions. Either of you or someone else, they need to make sure the food they are being served is safe. The thought of accidentally ingesting gluten can be stressful. So next is the number 7, initiate referral to the DM to ensure that nutrient and energy requirements are being met. There is no standardized by the management. So Aditian will help by assessing your nutritional status. C-section, what is nutritional assessment and recommended therapeutic diet to ensure you met your nutritional needs. Manage your symptoms and improve your quality of life. Number 8, discuss the importance of continued adherence to gluten-free diet. Even though the child is feeling well, eating well, and has normal stools, encourage a child to become involved in diet. So adherence to the gluten-free diet is low in youth with celiac disease. Adherence to the gluten-free diet and health-related quality of life may be significantly impacted in celiac disease, but little is known in ethnically diverse population. Number 9, adolescent compliance may be variable. Encourage support in understanding. Interventions to improve adherence are multiple: managing mental health issues appropriately, building a strong relationship, customizing the treatment regimen. So number 10, alteration in diet may have significant culture, ethnic, and religious implications. Help parents identify how adjustment can be made. How to support child with celiac disease. Learn about celiac disease in your spare time. Explore new foods with them. Check out gluten-free innovations. Set up gluten-free zone. Keep including them in social occasions. Check food labels and don't fuss. Number 11, advise parents on eating out. Check ahead of time with fast food chains and restaurant chips or management to determine if they can ensure gluten-free items. Be aware that even a gluten-free hamburger cooked on a grill with a breaded chicken breast cannot be considered gluten-free. So, example, many gluten-free menus at chain restaurants can be found on the internet by searching keyword gluten-free. Inform brands before visiting and bring gluten-free products if necessary. If necessary, consider implementation of formalized plan or necessary dietary restriction for appropriate accommodation in school settings. So number 12, advise parents to investigate support groups, internet companies, natural food stores, and major food brands that offer information and sell gluten-free products. So healthy balanced diet containing foods from each food group so they get a wide range of nutrients to help them stay healthy. Children's appetites vary depending on age, growth spurts, and how much activity they have done, so it's important to provide appropriate size portions. 13. Tell parents that common problems with long-term gluten-free diet are constipation, though low dietary fiber intake and weight gain due to now normal absorption. Therefore, encourage regular physical activity and avoidance of high-calorie food. People who repeatedly ignore the urge to move their bowels may eventually stop feeling the urge. Not enough fiber and fluids in the diet. A diet too low in fiber and fluids and too high in fats can contribute to constipation. Fiber absorbs water and causes stools to be larger, softer, and easier to pass. Number 14, impress on the parents the importance of regular medical follow-up. Regular medical checkups allow doctors to pick up signs of diseases that the patient may not even know to exist. With routine screenings, the doctor can diagnose potentially severe or life-threatening conditions and prevent any kinds of risk before it is too late or it takes a turn for the worse. So number 15, encourage the parents to practice good hygiene to prevent infections because the child may be especially prone to infection if malnutrition and or anemia are present. Good personal hygiene helps stop you from getting sick and spreading germs. Washing your hands often is a good way to stop the germs on your hands making you sick. Bathing or showering often helps prevent infections. So number 16, advise the family that the patients with celiac disease have a predisposition to non-response of the hepatitis B vaccine. Therefore, titers should be considered. Postulate that celiac disease patients may have significant predisposition to hepatitis B vaccine non-response, both celiac disease and hepatitis B vaccine. So number 17, help the parents to understand that the emotional climate in the home and around the child is vitally important in maintaining the child's medical and physical stability. Stress the importance of not making the child feel abnormal or a nuisance to the family. Family support is invaluable in facilitating acceptance of the diet. Some people dread social events or frequently decline to go at all because of their symptoms such as fatigue, migraines, joint pain, itchy rashes, or a constant need to go to the bathroom. These can create feelings of social isolation, depression, and anxiety. So number 18, stress that the disorders lifelong. However, changes in the mucosal lining of the intestine and the general clinical condition of the child are reversible when dietary gluten is avoided. So if you have celiac disease, the mucosal lining of your small intestine is damaged. This causes inflammation of the villi, referred to as bilious atrophy. As a result of this inflammation, the surface area of your small intestine, which enables the absorption of nutrients and minerals, is seriously reduced. So, number 19, advise screening for all first degree relatives because of hereditary nature of the disease. Screening is recommended for all first degree relatives of a proband. An alternative approach is the testing of the unaffected parents for mutations. So number 12, advise parents to investigate support